I have been overweight since, I think, before kindergarten. Chubby little kid, you know, and all my life. Always tried to lose weight. I think I've tried every diet known to mankind.
I had been heavy for quite a while and I'd struggled with it. I'd gone up and gone down. I'd lost quite a bit on my own and kept it, you know, I could keep it off for a while, and it always creeps back.
The way our society definitely has a stigmatism towards people that are overweight, because I've seen people react to me differently than they did when I was 400 pounds.
My diabetes got progressively worse because of my weight, and I was on an insulin pump before I had my surgery.
I was pre-diabetic. I was heading down a path that was just where I was told that if I kept going, I wouldn't be walking in just a short amount of years because it was just getting so bad. I had a young son at home I couldn't run around and play with. I was constantly tired, depressed, everything, all those things that you might associate with not being able to be a part of the real world out there.
I've tried every diet, and I don't want to say fads, but I've tried other nutritionists. I've had pills. I've had a number of different attempts at losing weight, and had a difficult time. And the heavier I got, the more difficult it was.
Chronic asthma, never under control. I've had high cholesterol, had high blood pressure, and I have a disc problem where I've had some discs fixed in my neck and they were going to head to my back, and was told that I probably would end up in a wheelchair in the not too distant future, or with my asthma not around at all.
Welcome to the bariatric information session. This is Fingerlakes Bariatrics, and I'm Dr. David Okalika. It's a pleasure to speak with you about bariatric surgery. I'll be doing this presentation in conjunction with Dr. Carl Weiss, who will be giving the second half of this presentation. You're welcome to follow along on the slides that I'll be speaking about. And if there are any questions in regards to this video, you're welcome to ask them when you come into the office and you're seen in person if you're going to be watching the information session video online. The bariatric program at Auburn Community Hospital has been here since 2005. There have been almost 2,000 patients who have come through this program. The surgeons who are performing bariatric surgery include myself and Dr. Weiss. We're both board certified and fellowship trained in bariatric surgery. There are many people who are involved with the bariatric program that are listed here. On the slides, they include Dr. Weiss and myself as the bariatric surgeons. Ro Herbert is our bariatric coordinator. Kim Bertonica is our bariatric nurse. All of these people that I described are part of the bariatric program, and they're all available to the patients for whatever needs or questions that arise. This is a picture of the operating room normally used for bariatric surgery. The room is a state-of-the-art operating room equipped with all of the features that would be necessary to do advanced laparoscopic surgery, which is what bariatric surgery entails. And again, we have a full support of operating room staff, including the anesthesiologist and the nurses in the operating room for bariatric surgery. As far as obesity is concerned, the bariatric surgery that we're performing is available to treat morbid obesity and complications of morbid obesity. The obesity epidemic in the United States is profound. It occurs in epidemic proportions, with up to 25 to 30% of population being in the obese category or carrying a diagnosis of morbid obesity, and to 2/3 of individuals in the country being overweight. Obesity has social implications that are listed, including social discrimination, which is an issue. It has a major impact on society, and that includes both financial implications as well as medical and health implications. And it's a tremendous burden on our society, and there's a lot that we can do to improve patients' health and decrease their weight with bariatric surgery. There are environmental causes that affect obesity and have increased the obesity rate and the obesity epidemic. So these include things like immobility, portion size, as well as a sedentary lifestyle and sedentary society. And you see all of that listed here on the slides. Patients are also exercising less and are at jobs also where they're sitting most of the time and their activity level is lower. So all this translates into a obesity problem. As I said, it's getting worse nowadays, and it's a major disease that we're trying to treat with bariatric surgery. In the past, going back 50 years maybe, obesity was seen as a personal weakness or failure. It was not viewed as a disease per se. Diet and exercise were the prescribed treatments, and weight loss surgery was available, but it was viewed as dangerous, extreme, and was not commonly performed. This has now changed over the last 20 to 30 years, and the outlook has changed even more dramatically over the last 10 to 15 years. Now we realize that obesity is a disease, it's a serious health problem. It has many serious medical conditions that go along with the disease, and surgery has gained acceptance as a way to treat this disease, even though it's still not considered first-line treatment, but for patients who have suffered with obesity for many years and have medical conditions that go along with it, surgery has become safer, more effective, and the programs that we've developed around the country to do bariatric surgery have improved the outcomes and patient satisfaction overall. There are other options that should be attempted for weight loss that should be tried before bariatric surgery. These include diet, exercise, and behavioral changes. Overall, there is some positive effect from these treatments, and patients can lose weight in the short term. However, long term, it is difficult to maintain weight loss with these medical or conservative options. There are weight loss drugs, which also have a smaller effect on weight loss, can be used in the short term, but are not considered long-term treatment and are not durable treatments. Weight loss surgery or bariatric surgery overall is the most effective treatment. The excess weight loss typically is between 50 and 80%. And overall, it's the most durable long-term solution for morbid obesity and for metabolic syndrome, which we'll get into in a little bit, which describes the medical conditions that go along with obesity. Some of the health problems that go along with this metabolic syndrome that I'll describe include diabetes, which we see very commonly, high blood pressure, high cholesterol, heart disease, fatty liver disease, sleep apnea, which is trouble breathing while you're asleep, gallstones, urinary incontinence or urinary leakage, joint pain, depression, risk of cancer, which is slightly increased in the obese population, and this includes things like colon cancer or gynecological cancer, asthma or difficulty breathing or difficulty breathing while performing exercise, or esophageal reflux, which includes heartburn or acid reflux, or indigestion. As far as the classifications of obesity, we use a table which is called a BMI table, which is a body mass index table, which is an index or a ratio of weight to height. By using this index, we can come up with a number which is used to categorize the level of obesity. So what's listed as grade 1, which is basically overweight, is a BMI of 25 to 29. Severely overweight is a BMI of 30 to 39. And morbid obesity is considered a BMI of 40 to 59. Super morbid obesity would be considered a BMI more than 60. As far as surgery and the categories of obesity that are candidates for bariatric surgery, these include the higher two categories, a BMI of 35 to 40 in a patient that has obesity-related medical problems would qualify for bariatric surgery, and a patient that has a BMI of 40 or more, even without any associated medical problems, would qualify for bariatric surgery. Now, why would anyone want to have bariatric surgery to lose weight? The reason is that, as I described, most people are unsuccessful over the long term losing weight with conservative measures or with medical weight loss. The rate of maintaining weight loss over a long period of time with medical options or diet and exercise is very low. Surgery is the most effective method to treat severe obesity for patients who have struggled with weight for several years or more, have associated medical problems, and are willing to make a lifestyle change to make the surgery successful and improve their health. So, as far as guidelines and candidates for patients for bariatric surgery, as I mentioned, a BMI of more than 40 would automatically qualify you for bariatric surgery, or a BMI of 35 or more would also qualify you if you have obesity-related health problems. You have to be 18 years of age or older, and you have to have been overweight for more than 5 years. As mentioned, regular follow-up is important, lifestyle changes are important, and these are the patients that are most successful overall with bariatric surgery. Who is not eligible for surgery? Patients who have an active substance abuse or drug abuse problem are not eligible. Patients who have eating disorders or other uncontrolled psychiatric problems are not candidates. Patients who are extremely high risk for surgery from a medical or anesthesia perspective are also not candidates. Patients who have lack of insight or family support about the surgery and what's expected both before and after the surgery are also not candidates. And if for patients who have unreasonable expectations about the surgery, or patients who think that the surgery has miraculous possibilities, also may not be candidates. All of these issues that I'm describing are screened for in our bariatric program and the process that the patients will go through to make sure that these conditions are not present and would cause problems with bariatric surgery in the future. Other medical conditions that would preclude bariatric surgery include inflammatory bowel disease, which have subcategories of colitis, lupus, or Crohn's disease. As mentioned, patients who are extremely high medical risk, patients who have liver disease, including cirrhosis or portal hypertension, and patients who are on long-term steroid treatment, which includes prednisone or other steroid-type medications. As far as the preparation for surgery, all patients need to be medically cleared for surgery. All patients need to undergo a psychological assessment. All patients have to complete several months of medically supervised weight loss in the program before coming to surgery. All patients would undergo an endoscopy, which is looking in with a camera in through the patient's mouth to evaluate for disease in the esophagus, the stomach, or the beginning of the intestine. And the patients also have to make some behavioral changes and show behavioral compliance with the changes that need to be performed to make bariatric surgery successful and to have a good outcome with bariatric surgery. All patients would need to go through at least 2 to several months of preparation before coming to surgery, and a lot of this is also mandated by the insurance companies that we would try to get approval from in order to perform bariatric surgery. Behavioral compliance. A lot of what would be explained by the dietitian in preparation for surgery is how to include protein in your diet, participation in support group, which is a meeting where patients can meet other bariatric patients and learn more about bariatric surgery from the patient perspective, and to increase their exercise and exercise tolerance, which also is very important after the surgery to make the surgery successful. In addition to this, we require some preoperative weight loss in the program before surgery. And this makes the surgery technically easier to do. It shrinks the size of the liver. It makes the work that has to be done in the stomach easier to perform. It increases the likelihood for long-term success since patients know what they have to do as far as weight loss before the surgery. And again, this will help them after the surgery. And it shows some behavioral modification and lifestyle changes that also are necessary to make bariatric surgery successful. Now I would just like to introduce Dr. Weiss, who will be presenting the different bariatric surgery options, and he will continue this presentation.
when I met with Dr. Weiss. That was probably in September, and it just seemed very genuine. Caring, listened to me, listened to my questions, my concerns, had good answers for every question I had. He had an answer. It wasn't, well, I'll get back to her, I'll look it up, or I'll figure it out. It was straightforward. This is how it is. This is what you're going to have done. This is the procedure that I like. People have good success with it. Some people have lost 50 pounds. Some people have lost 150 pounds.
Everyone in the hospital was incredible from the first time I came in and to today. They're very encouraging, and they're just so helpful. Even just the hospital staff, while I was here had the surgery, the nursing staff was wonderful.
After I had surgery and began to lose weight, the weight loss was actually very slow, 1 to 2 pounds a week. But it's been a year and a half now, and now it's 105 pounds gone. So it goes by quickly, and it's been great.
The staff at the hospital is the best. They help you every step of the way. The support group meetings on Wednesday nights are extremely informative. They have different people to ask questions, to answer questions every meeting. You get nothing but professionalism and nothing but help from this staff.
They're all very nice, very informative. They kind of give you all the pros and cons, different options for different surgeries that they can offer you. So that was really beneficial. And the other thing that was nice is they offer a nutritionist that you can see. When you go through their program, you can see the nutritionist free for life. So even after the surgery, you still have that support.
Hi, Carl Weiss, Dr. Weiss. I'm the director of the bariatric program. I'm chief of surgery here at Auburn Community Hospital. I'd just like to talk about our bariatric surgical operations that we perform. We'll focus primarily on the lap band, gastric bypass, and sleeve gastrectomy. The lap band, we've performed quite a few. We're comfortable with band management, and we can elaborate on the details of surgery for the particular patient. I'd prefer to discuss it one-on-one in terms of what our thoughts are in terms of the patients who might do well with the band and who won't, etc. So we'll focus more on gastric bypass and sleeve gastrectomy. Sleeve gastrectomy is our most popular procedure. It's what we do most of at this point in time. It's basically changing the shape of the stomach. As you can see, this is a staple line. It's a very effective operation. We see very consistent results. It's by and large a metabolic operation, which means it profoundly changes appetite and portions, and it seems to be very consistent in terms of its effect. It takes about an hour in the OR. Hospital stays about 2 days. Recovery is about a week. Most patients lose the majority of their weight over 1 to 2 years. It's a very prolonged process. We're pleased because the patients are pleased. That's why we seem to be comfortable with recommending sleeve gastrectomy for most patients, to be honest with you. Some of the advantages: there's no concerns for marginal ulcers, which is a distinct advantage over gastric bypass. There are no concerns for internal hernias. And again, it's a very profound change in appetite and portion control. We don't change the natural anatomy other than working with the shape of the stomach. And there's no need for any work with the bowel. So that's, again, a distinct advantage over gastric bypass. Gastric bypass is the time-tested, the gold standard. It's been around for 50 or 60 years. It's a very effective metabolic operation. It's the best treatment for patients with severe diabetes, severe blood pressure issues, or high cholesterol. Gastric bypass is a 3-part operation. Part 1 basically is to divide the pouch. Part 2 is to divide the bowel. Part 3 is to reconnect. So in the operating room, laparoscopically, it takes about 90 minutes. Here's part 1 where we divide the pouch. Here's part 2 where we divide the bowel. And part 3 is where we have to put things back together. We bring the bowel up and we sew it here and we sew it there. And basically the food goes around the stomach. And that's the mechanism for gastric bypass's effectiveness. It's a very effective metabolic operation. Basically it treats diabetes, and patients become insulin sensitive soon after surgery, within days, which is a remarkable event, basically. Gastric bypass takes about 90 minutes, 2 hours. I call it the rule of twos: 2 hours in the OR, 2 days in the hospital, 2 weeks to recover. The patients lose the majority of their weight after about 1 year. Basically what happens is the body adapts to the surgical changes and the weight loss slows or stops and stabilizes. But at the end of the day, success is determined by those same 3 principles that we talk about for any patient. It's basically protein-based nutrition, exercise, and come to support group, because patients will lose their weight for a year and fail at 3, 4, 5 years if they haven't changed behavior. The same concepts are critical for success. It's a 3-part program. Protein-based nutrition, understanding what that is, finding a way to burn calories on a regular basis, and come to support group, because your habits have led patients astray before and they certainly will again in the future. So, all right, here's a sequence of events. This is our information session. If you're interested, you can log in, and that will generate a chart, and we can interact with you by whatever means you'd like, whether it's phone or email. We'll look at your policy to make sure you have coverage. We'll send you a letter in the mail to make sure we can establish communication. We'll set up an initial office visit with myself or Dr. Okalika where we can discuss our individual concerns with you. We'll set up a regular doctor visit with your primary care doc. We like to have their support. We'll have you see consultants who might be necessary to minimize surgical risk. And weight loss matters. We really want to emphasize preoperative weight loss because surgery is safer, surgery is easier, it minimizes risk. It also means that patients are able to change their behavior, which we're very, very much in favor of for long-term success. And a few other steps here: insurance approval. We've got to make sure your insurer is involved or supportive. And last but not least, we have to schedule the operating room, and we're scheduling several months out at this point in time. So in terms of affordability, we'll look at your insurance coverage, look at your policy. Sometimes insurers will deny the initial attempt to get approval. That's not the end of the road. We can appeal that denial, and oftentimes we have success with that process. If anybody has any additional questions or certainly wants to see us face-to-face or wants to interact, please call or email, and we will happily respond as quickly as possible. So let's hear from some of our patients about their experiences, and we've been very pleased because they've been very pleased. So I'd encourage any patients who want more information to go online, see some of these video clips, or talk to our patients directly.
I wish I had done it sooner. I really do. I love the way my body's changed. I love the way my confidence has changed. I love the fact that I'm going to be here for my kids a lot longer.
Once I had the procedure, about a week later, I started walking, and it was incredible just to be able to walk. And all of a sudden, the asthma wasn't bothering me, and I was like, it was just incredible to walk around the block and not have my inhaler in my hand, puffing it.
It's just been the best thing I've ever done.
My father passed away at 40 years old. I'm 48 years old. I think that I deserve a little bit longer life than 48 years.
You look at it as a last straw, and finally one day somebody said, "Patty, it's your life." And that's exactly what it was. I had a chance at an age to regain my life.
I can't say enough about it. It's a great program.
I have energy to do things that I never had before. I can sit in chairs and I don't have to worry whether I'm going to fit in that chair or not. I can cross my legs. That's like a huge thing because I've never been able to do that before.
My daughter is 19 and a half months. You know, I knew once she got going that if I needed to chase after her, I wasn't going to be able to do it at 400 pounds. So just to know now that she's able to rip roar around the house and I can keep up with her and not get winded and not be able to do the things that a father wants to do with their kids. So as I know as she gets older and she gets bigger and we can play outside and run around, that I'm going to be able to keep up with her. And that just makes me feel great.
This has changed my outlook on life because I know now that I'm healthier. I know that I'm going to live longer. And I know that I'm going to be there for my family, and that is the one thing that really motivated me to this. I want to be there and grow old and be able to see my children grow up, and that's important to me.
I truly believe I was put on this earth to be a grandmother and want to be around for grandchildren.
When we retire, we want to be healthy and able to enjoy our grandchildren and be able to vacation with our families and be able to do things. We don't want to be confined to the house.
There's so many things that I want to do that now I can't do. I mean, we went somewhere and I rode on an airplane. And I said, I have room in the seat. I can move this way, I can move that way. I don't need the extent. It was just incredible. That little thing was incredible.
It's the best thing I ever did for myself.